Right, everyone. I think we'll get started for the day. Welcome to the September Helen seminar. I'm Chris Gingell. I'm one of the directors of the Helen Network. I want to start by acknowledging that no matter where we are in Australia, we are zooming in from for today's meeting. We will be on unceded Aboriginal land. And I want to particularly acknowledge the traditional owners of where the Melbourne Law School sits, where Helen is based, and that is the Wurundjeri Woi-wurrung people of the Kulin Nation. And we pay respects to their elders, past, present, and future, and also want to acknowledge the importance of Indigenous knowledge in the Academy. So we have a really interesting seminar today titled "What makes pediatric ethics different?" And we have two speakers, Georgina Hall and Jenny O'Neill. Georgina is a clinical ethicist at the Children's Bioethics Centre, where she has worked since its inception in 2008. She has over 15 years' experience in pediatric clinical ethics consultations, research, and policy development. Her work spans topics such as pregnancy screening in adolescents, parental refusal of treatment, and shared decision-making in pediatrics. Georgina leads the Children's Bioethics Centre's education program, delivering teaching for staff and students and coordinating the annual Paediatric Bioethics Conference, which just wrapped up Friday last week and was a very successful conference. And we also have Jenny O'Neill joining us. Jenny is the inaugural clinical nurse consult in bioethics at the Royal Children's Hospital, where she has worked for over 20 years in roles spanning emergency, surgery, medicine, and adolescent health. She holds a PhD in nursing and a master in bioethics, and also works in nursing research as an honorary fellow at the University of Melbourne. So we have two very talented, lovely speakers today. And I'll now pass over to Georgina.
Thank you, Chris, very much, and thanks to everyone for joining us here today. It's a pleasure to be able to share with you a lot of the work that we do in here, I guess our processes and our ways of offering and supporting clinicians in the ethics space. So I'd just like to echo Chris and acknowledge that we here at the Royal Children's Hospital are also on the Wurundjeri land, the people of the Kulin Nation, and we also pay our respects to their elders past, present and emerging. I'd like to also introduce my co-presenter, Jenny.
Yes, hi everyone, lovely to be here.
We're in the same room, but we're using our own screens just for simplicity. So if it looks a bit strange, that's what we're doing. So as Chris mentioned, the Children's Bioethics Centre has been here and working at the Royal Children's Hospital in Melbourne since 2008. So that's some 16 odd years. It was the first paediatric bioethics centre in the country and still remains the largest centre nationally. It was set up, if we want to have a little bit of a historical look, when the Children's was in the same health network with the Royal Women's, there was a controversial case of a late-term abortion termination for suspected dwarfism, which created a great legal and publicity storm for the clinicians involved, and that led to both hospitals' executives seeking clinical ethics guidance and embedded in practice from then on. So that really was the seed of the Bioethics Centre, which then sort of formalised as a centre in 2008, and from which we go from today. So just to give you a brief overview of the four pillars that we're built on, and mainly it's our clinical ethics service, which is what we'll run you through today, where we offer confidential one-on-one advice to any clinician within the hospital. That can be medical, nursing or allied health staff. We also then can attend multidisciplinary team meetings and provide some ethics focus for some of the questions in the discussion. We can also hold an ethics MDT where we invite various team members or team members from various disciplines or craft groups involved in a particular patient's care, and we would chair that. We also speak with families and parents and children themselves when the clinician has asked for that, or perhaps when the family has asked for that. And then on the other side of that, we also offer staff debriefs following a particularly challenging case. We also have input into guidelines and policy documents for hospital executive, and we have a thriving education program with workshops. We do 4 grand rounds a year. We teach the junior resident medical officers. We do podcasts and have e-learning units, and we also host a number of sabbaticalists from overseas and within the hospital, and usually end up authoring some journal publications with them, as well as hosting interns most semesters from the Monash Bioethics program. So it's a cracking pace. So just focusing now on the clinical ethics service that we run. As you can see, we're pretty steady over the last 2 years with 83 referrals, which may not seem like that much of a jump from previous years. However, the way we calculate the information of what goes on, there really has been an upscale in the last couple of years, owing often to the complexity of the cases, the medical complexity as technology increases. And also perhaps we have noticed, I guess with Dr. Google out there and the focus on autonomy, a shift in terms of families accepting or supporting medical advice and guidance. So the ethics services have been well used. So you might wonder where do the referrals come from in the hospital? Well, as you can see, there's a broad spread across so many departments, from neurology and neuro disability and development, the adolescent healthcare service, the cancer centre, gen med, respiratory, burns, bone marrow transplants, orthopaedics, cardiology, PICU and NICU, oncology, and our gender service. So we have a wide spread, and you can imagine a wide spread of the types of cases and the flavour of the referrals. So you might think, well, what types of cases or referrals are you getting? Well, a few years ago, we did an audit of a 10-year period of the types of cases that were referred to us from clinicians, and these are the top 7 types of cases that tend to cycle through. Firstly, medical uncertainty, perhaps within teams or between teams, about what would constitute the best treatment for this child at this time. A big one is when parents are disagreeing with the medically recommended pathway for a child. That could be them refusing medical management as being suggested by the clinical team, or not wanting recommended management, or wanting it, or perhaps wanting to focus on complementary or alternative treatment and therapies, and the rubber hits the road when those are introduced within the hospital context for various reasons. There are also situations when parents are disagreeing with each other. While consent of one parent might be sufficient, there's obviously broad interpretation of that and implications for the relationship and for the family unit with how that's navigated and managed. Also, the child or the young person themselves can refuse medical treatment that the parents have consented to. So that can bring with it layers of questions and not knowing what to do. So to that point, how much we involve the child or the adolescent in their medical journey and their treatment planning, that covers areas like truth-telling and how much ethical weight we accord to their viewpoint or their preferences. And then concern around who should access what information and who provides that to the family or the extended family or the patient themselves. And then being in a public hospital, concerns about resources, justice and equity are always ever present. So the 3 key areas of challenge in that typology are when parents and doctors disagree, dealing with adolescent consent and refusal of recommended treatments, and then younger children resisting treatment. So we thought today that what we would do would be to take you through a little bit of the ethical content of how we frame our service and how we offer help to clinicians. And we'd really love to hear your thoughts, your questions, your views, your ideas. That's the way we run our sessions here. They're very interactive. So we're going to get to 2 case studies, and we'd love to hear what you think. So please feel free to raise your hand physically or virtually, and we'd love to hear from you. So firstly, if we think about how we approach ethical concerns, we need to first think about what is it that we're worried about. As one of our ethicists, Claire Delaney, used to say, where's the ethical heat? What's going on? Where are the tensions and what's at stake here? Often there are competing or differing views about what the degree of benefit or burden is for the patient if we choose this option or that option. How much weight should be given to all those different views? And then I guess at the coalface, what are the goals of care? Where is this all going in the long term? What about people's different ideas, or when there is no clear idea? So that's kind of what we're circling around. These are the types of questions that clinicians, other team members and family members may have. So how do ethical principles help us? Well, principles are a standard way of thinking about ethics in healthcare. They're not discipline specific. There's not nursing ethics and doctor ethics and allied health ethics. They are the basic healthcare ethical principles that we all abide by and are aware of and cognizant of in our roles. So principles is really just a fancy way of saying these are the values, these are the things that matter. And how are we going to put them into action? So you might have a personal set of values. You might have values as a family or the school that you went to. The legal profession has its own set of values. So ethical principles in healthcare are the values that we as a profession hold to be important and that are important to uphold. But they're not rules. They're not binary. They're not black and white. And that's where we come in. We're muddling around in the grey. So a lot of you are probably familiar with these 4 healthcare principles, which are, I've got to say, upheld in Western democratic societies. There are a lot of other ethical principles, Eastern philosophical theories that underpin practice in other countries, Middle Eastern, but these are the general bread and butter, I guess, in the West. So they are beneficence, doing good, benefiting, helping others, non-maleficence, doing no harm, which is obviously something that comes to us from the Hippocratic Oath originally, autonomy, self-determination, self-government, and justice, fairness and non-discrimination, and fairly allocating resources. So how do these principles then map into the paediatric context? Well, the way that we have seen them develop is that beneficence and non-maleficence kind of merge, and that's all about promoting the well-being of the child that we're caring for. Autonomy, interestingly, sort of stretches and changes a bit when we're talking about paediatrics because I guess principally we need to respect the parents as the legally and ethically mandated decision makers and caregivers for their child. They're the ones that make decisions on behalf of their child. But we also at the same time have to respect the child as a person with developing and future autonomy. And we also see the role of the healthcare clinician as helping scaffold that autonomy as a young person develops, especially, I guess, if they've got a chronic condition and they need to take those skills into adult land, as we call it. And we also have to respect the privacy of the child, which is something that really becomes apparent in the teen years. It's something that young people are really striving for, and it needs to be recognised and accommodated in that sort of gentle dance with the parents. And then obviously distributive justice principles remain the same. So you might think that's great. We've got those principles. We've adapted them to paediatrics. We can go. We're armed with all the tools that we need. But principles and ethics is a messy affair and it can get quite complicated. And that's because well-intentioned and intelligent people can start with the same principles but interpret things very differently. What does harm mean to this person? And what does their interpretation of harm mean in this situation with the child? Same thing with the nurse, same thing with the doctor, perhaps the same thing with the music therapist. They all might have different interpretations of what constitutes harm or benefit to a child. And sometimes principles can seem to require different things. If we honour one principle, we're giving up on the other principle. So how do we balance and make sure that every decision is the correct weight and balance of all the principles that might be competing? And what do we do with, I guess, the moral fallout for clinicians if they believe that some of the practice that they're engaging in is not ethical or is kind of not giving enough credence to one certain principle over another? So the way that that we have developed our process here at the Royal Children's Hospital is the 7 steps model of clinical dialogue, critical clinical dialogue. And this was really articulated well with our ethicist Claire Delaney, who was the lead author on a publication which mapped it out. So the steps, very briefly, are active listening to all stakeholders, hearing their perspectives and their understanding of the situation and what's informing their understanding. So the first step with that then is to gather and unpack all the info. And often by the stage that a case is referred to us, there is a lot of info, there is a lot of noise, there are a lot of social factors and influences. Maybe there's some rumblings within the team or some disagreements. So it's about carefully eliciting all that. Then we try and close in on the ethical question, which might be slightly different to the one that was brought to us. Then as a group, we would identify possible ways forward, and then identifying what are the pros and cons of each of those outcomes, weighing and balancing all the considerations, and then perhaps not necessarily tying it neatly in a bow, but settling upon some agreed outcomes, some ethically justified ways forward that clinicians are then able to take on board. But just to emphasise, our service is completely advisory. The clinicians, the buck stops with them. They make the final decision. Often they're just wanting to help unpack these complex situations and then look for a way forward. So at this point, I am going to head over to Jenny O'Neill, who's going to present the first scenario, and we'd really love to hear some of your questions and thoughts when Jenny asks.
Thanks, Georgina. So our first scenario is looking at the first issue that's kind of pretty specific to paediatrics of when doctors or when clinical teams and parents disagree. And so the scenario I'm going to introduce you to is Tahir. So Tahir is based on a real case with some details changed, and Tahir is a pseudonym to protect their identity. But this is a really common type of scenario we see where parents want everything done, aggressive interventions to preserve life in the context of clinicians who feel that perhaps it is time for a child to move towards a palliative pathway. So Tahir is a 10-year-old boy, and was born in Sudan to Sudanese parents. He came here in the first year of life as a refugee with his mother and 4 siblings. We don't know where Tahir's father is. He's still in Sudan, and the family haven't heard from him since they left the country. So Tahir's mother, Sama, is a single mother to 5 children. Tahir has severe cerebral palsy, so the most severe type. He requires full care, so he's wheelchair dependent with quadriplegia. He can't move any of his limbs, and he also can't hold up his trunk and his head, so he needs support to sit, a supportive wheelchair. He's medically very fragile, so he's in respiratory failure. So this means that he's requires assistance to breathe, especially when he's asleep. So he has nighttime respiratory support with a mask, BiPAP mask, similar to you have when you have sleep apnea. He's fed through a tube in his stomach, so he doesn't have a swallow reflex, so he's unable to feed safely, and he's also unable to control his own secretions, so he needs suctioning of his secretions throughout the day. Tahir's clinical condition has deteriorated over the past 12 to 18 months. So while cerebral palsy is a static condition, the medical complications mean that the health of a child or young person with cerebral palsy, severe cerebral palsy, does deteriorate over time. And this is partly, his deterioration is partly due to a rapidly progressing scoliosis, so a curvature of the spine, which is really common if a child doesn't weight bear. And also lots of aspiration events. So even though Tahir doesn't feed, he does, he has micro aspirations of his secretions that go down into his lungs, and that causes pneumonia or lots of lung infections. Tahir doesn't have a reliable communication method. He's non-verbal. He does cry or grunt when he's distressed, but otherwise he can't communicate. So to continue him, in the last 4 months, Tahir's had multiple admissions to our paediatric intensive care unit, so roughly every four weeks for increased respiratory support, and this is in the setting of getting lung infections. He's currently in intensive care. He's receiving the maximum of the non-invasive ventilatory support. So that is the support to breathe. So a mask providing the positive pressure to assist his breathing. And he's getting very tired and exhausted from working so hard to breathe. If he deteriorates further, the next step would be put a tube down his throat into his lungs to intubate and then ventilate him that way. And it's possible that if that's done, his lungs would never be strong enough to be able to remove this. So we're going to stop here and ask some questions. Do you just want to go first? Firstly, just your initial reactions would be really good, and you can either put up your hand or yell out or put in chat. Listening to that story and the information you have so far, what do you think should happen if Tahir deteriorates? And Peter's got his hand up. Peter, do you want to...
Yes, thank you. Peter Ryan from Monash Health, and unfortunately had a similar situation with Edwards syndrome recently that was deeply troubling. So I would start as a lawyer with the legislation, and my thinking would be framed in terms of saying, well, okay, under the legislation, the clinician does not have an obligation to deliver care which is, first of all, futile, but secondly, more importantly, is non-beneficial. And then the question then arises is, as both legally and ethically, is this treatment non-beneficial or not? And is it in fact doing harm? And in answering that question, I would be looking at, the zone of parental discretion and whether we're operating in that zone or whether we're comfortably out of it. And then secondly, allied to that, I would be bearing in mind that the legislation doesn't require, in these circumstances, the consent of the medical treatment decision maker to palliation, but there is obviously the obligation to consult. So I'd be starting within that sort of difficult grey framework, trying to connect the way the legislation works with the clear ethical issues in the matter,
Right.
and into his best interests.
Yeah, and so that's a beautiful example of where kind of ethics and legal elements talk together well. It doesn't always happen. When you say though, the treatment might not be beneficial or indeed do harm, and this is, I think, implied, but we do lots of things here at the Children's that cause harm to children. And so we always need to balance that against the benefit. So yes. I think that's, we need to look at what our goal is here. And is that goal, I don't know, what do people think the goal is here? Because if we have a goal that's beneficial, and to do that we have to do some harm, there's a balancing act.
Well, it's not curative. This situation, I'd be struggling to see the benefit in terms of outweighing the distress, if any, that is being caused to Tahir, for example, by maintenance of the current breathing regime, or alternatively going to ventilation, and understanding the distress and pain that might cause in circumstances where the prognosis is pretty appalling.
Right. So what you're bringing in there is Tahir's experience. And what do we think Tahir's experience is? If we talk about suffering.
Yeah, so this is, sorry to jump in, but this is where I would sort of ask the treating team, the clinicians, does Tahir seem distressed when he's in those admissions? Does he seem like he's in pain in those admissions, although he's not verbal? What are your impressions of it? And then I also would be wondering, well, what's the best possible case scenario, or the best, plausible case here? Like, is it likely at all that if we intubate Tahir, that he will make a recovery and be free from hospital care, or are we just prolonging this distress that he's feeling with more and more admissions over? So those are the questions that I'd be sort of asking the treating team.
I think that's a really great point, Chris. And I think from building on what Peter has said, Peter was very much focusing on trying to make the medical decision about what the benefits and the burdens are of this treatment, and perhaps moving towards a futility, and also what's the legal framing. I think it's important, though, to touch on what Peter also touched on, which is the zone of parental discretion. We need to think about what is it that the parents want. I wonder whether anyone has any questions for the parents. Do we want to know what mum thinks, what mum wants for Tahir?
Yeah, so does anyone else want to put their hand up or unmute themselves and talk? If not, I am happy to keep going. Yeah, so I guess I would be interested in, sort of following on from my last point, what does Tahir's mother see as the long-term goals of this treatment? And particularly, does she have does her view about the long-term options for Tahir sort of cohere with the medical reality here? So those are the questions I'd be interested in. And what does she want for Tahir?
Yeah. So that's a really good point. We might keep going. So you've asked some really good. So what you've both done, or Peter's got his hand up. Yeah, Peter.
Sorry, I was just saying I totally agree with that. I think there's an obligation to consult. There's certainly no doubt a legal obligation, and an obligation to take into account, their preferences. I strongly agree.
So if Tahir was a typically developing 10-year-old, would his voice come into this at all? So Tahir can't explain to us what he would want to happen to him. And part of the reason for including the parents is that they're usually the closest proxy voice to the child. So we can't ignore the parents completely. We legally could, but ethically we can't.
So before I pop that question up again, if we let you know that mum is steadfast in her belief that everything should be done for Tahir, and that should continue the whole way through, that would then bring us perhaps to this question of what are the ethical principles that are at stake in this situation for Tahir's treating team? What are the things that are at tension?
You can just think back to the old four reliable.
Well, yeah, I can, I jump in. So, I used to do lots of exercises where you got these case studies and you had to apply all of the principles. So, but look, I think, clearly clearly, I would see all principles operating here. So I would see the autonomy, particularly of the mother here, and particularly, she's making medical decisions for Tahir. We think that she's the, a medical decision maker. Then we, of course, need to consider her point of view. But I would tinge that autonomy then with, does she have a clear view of the medical reality here that is she's basing her decisions on? Um, I think the beneficence really needs to be called into question. What is the benefit, as Peter was saying? What actually is the benefit of this treatment? Are we just prolonging suffering? Again, I would phrase that with non-maleficence as saying that, we've got to be really careful here that actually what we're doing is actually just prolonging suffering and causing more harm to Tahir. And I would think also the justice concerns are how much medical resources are we using for Tahir in what might be a futile treatment, and is this the best use of resources, and is the best use of the treating care team he's been readmitted every few weeks or so? Is that a good use of clinicians' time? And is, those are how I would be kind of like thinking about it.
Chris, thank you for throwing that prickly pear in at the end, the justice issue. And that is obviously something that hovers over a lot of the care that's provided here. What we find with our clinicians is that we have to remind them that while they need to be mindful of those kind of justice and resource issues and the bed pressures issue, their mandate is to work with their patient and work in their interests. So while those kind of concerns might come upstream, downstream, in this moment for Tahir and his mum, the clinicians need to be mindful of their duties towards him. So I guess we're down to the two principles in tension, aren't we, of promoting the well-being of Tahir, so harms and burdens and benefits, and mum's wishes for Tahir. So Jenny, can you tell us, if Tahir does deteriorate and he does need to be intubated, can he keep going home?
So if he's intubated, I think the real fear is that he will not be able to be extubated. So the tube won't be able to be taken out because his lungs are in such a poor state. He has ongoing infections. He has scoliosis, so his lungs can't expand properly. He's got poor muscle tone, and the longer that he is unwell, and he's been unwell quite a lot, the less muscle tone he has. So what would happen is that he would be intubated and ventilated for a while, and then they would try him to decrease the ventilation pressures, and then try extubating him. And potentially, if he didn't breathe well enough, they would re-intubate him. And potentially, although it's not advisable, you could give him longer and then try again. But he may be stuck with a tube and breathing for that. And he can't go home like that, unwell like that. So then there would be a discussion about what to do, because while he's intubated and ventilated, he would have quite a lot of sedation. So it's possible he may not be aware, but you have to lighten that sedation to allow him to breathe on his own. So if you attempted to extubate him, to take the tube out, he would be aware of that. And the whole process of intubation and extubation, it would not be comfortable. Having said that, that pathway in the purest form of the word, Chris, isn't futile, because it would potentially extend his life. So that makes it not futile. It does do something. It just depends on our goals. Are our goals having the longest life possible at all costs?
So that life would be played out, presumably, all things considered, in hospital. So if we're intubating him, Tahir's world is contracting down enormously.
Yeah.
Okay.
And so I think that's, if you go to the next slide, I think that's a good segue into just skimming over some of the principles we've talked about here. So the first one being the well-being of the child, And that's about minimising the harms, risks and burdens and maximising the benefits. And when we think of the well-being of the child, quality of life is often thrown around. We really have to ask what we mean by that. What is quality of life, and who's judging that quality of life?
So I think what you're sort of getting at there a bit too is that you might have a new nurse on the ward. She might be 23 years old and have had very little exposure to cases such as Tahir. And she might say, well, there's no quality of life. He's just going to be stuck here in this room. So that's a cruel life and that's very harmful. So we shouldn't move to that. We should probably redirect towards palliation. So that's that nurse's view of Tahir's quality of life. And what are the dangers of framing it in those ways, Jenny, that we found?
So, I mean, I think there's a couple of things, and obviously the only person that can tell you what their quality of life is like is the person themselves. And in Tahir's case, he can't tell us what his quality of life is like, even when he's well. That's very difficult for him to communicate. So we're relying on someone else's view of that quality of life. And we normally, as I said, assume that parents are in the best position to determine what's important for that child. And we haven't, the other way we can tell quality of life is perhaps by objective measures. So looking at what Tahir enjoys doing, we haven't told you much about what he enjoys doing. I mean, about 12 months ago, he went to a specialist school and he was integrated into that community, and he smiled. He hasn't smiled for some months now. He smiled and he occasionally laughed. He liked being with his siblings. He liked music. He hasn't done any of those things for some months now because he's been too unwell. So we look at a child's interests when we're determining sort of, it's kind of a better way of looking at quality of life in terms of really breaking it down to what is the interest of this child in front of us. And this is a representation that Lynn and others published looking at what makes up the child's interests. And I think one thing we do say to clinicians is in our hospital, we get very skewed here as clinicians, and we prioritise the circles that have life and healthcare, because that's our core business, and that's what we're here for. And sometimes that's at the expense of thinking about the rest of the child's interests. And really, it's sometimes the parent's job to remember all those other interests and to bring those to the fore. But we should also be thinking about, well, what are the other interests here? And if we're prioritising life, but at the expense of all those other interests, how does that balance up for that child? Is that a life worth living if they've got life but none of those other interests? If they don't have the social identity, the sense of self, their play and pleasure has been curtailed, they can't go to school and unlikely to be able to re-enter school. So we need to think about all interests.
Yeah, so we do rely on the parents, and in this case, we'll be relying on to his mum and maybe his siblings who come in to visit to really help develop a sense of what is life like for Tahir and what will his life be like then if he's consigned to the rest of his days in hospital. Some kids don't mind being in hospital. Some kids can still advance their interests and their purpose, and they feel quite well supported and scaffolded in hospital. Whereas other kids, if they can't see their dog and go outside or be around their siblings, that would be a real burden to them. So we have to get a sense, and this is what we do in our clinical ethics meetings, of what is life like for Tahir and what would, I guess, the pathway of intubation and remaining in hospital, possibly for the rest of his life in a sedated state, what would that do to his interests? Does that set them back to such a point that our interest in the health and healthcare and life circles maybe has to start taking a bit of a backseat to some of these other interests that he has. So let's move on.
So, as I think both Peter and Chris pointed out, the bottom line is a basic benefits and burdens test. I'm sure that won't be new to anyone. So, but any intervention should reasonably be expected to produce more benefits and burdens. The thing is, a case like Tahir is that the stakes are really, really high. So we have to think about palliation being ethically appropriate or ethically justifiable if the burdens of keeping Tahir alive outweigh the benefits of that, what that life would consist of. The other reason we might consider palliation is if a child or young person's basic life is so terrible that death would be preferable. So it's not anything we're doing to them, it's just their very existence, and that happens in very rare cases. We had, one recently where there was a rare pain syndrome, so the child was in pain all the time, not from interventions we'd done, but because of a genetic condition that they had. So do you want to
Yeah. So
we'll give you a little bit more information about Tahir's case. So as we've alluded to, there have been repeated efforts to discuss limitations of treatment, so specifically no escalation to intubation and ventilation with mum. And she'll no longer engage in these discussions. There's been so many, and there's been many throughout Tahir's life, which is quite common with a child with severe disability. And Tahir's always pulled through, so she maintains that she wants everything done and Tahir will recover as he always has. So just to complicate things further, there's been attempts to increase pain medications to increase Tahir's comfort. So he's working really hard to breathe. He's got dystonia, so he's got muscle soreness anyway. And he's having lots of suction, which he hates and which is uncomfortable. So he's not comfortable, but any attempts to increase pain medications to help with this has been met with resistance by mum. And she's expressed that suffering is part of life in accordance with her faith. So think about what ethical principles, if any, are different at stake now, and what decisions need to be made and who should be making those decisions. Anyone want to chime in with what they're thinking?
If I could just add something here, and again, I'm sort of putting the lawyer's hat on. We're getting into a neck of the woods now involving the parens patriae jurisdiction of the court, in that you're obtaining expert medical evidence that would override the wishes of the mother. And this is, sometimes it's seen in blood transfusion cases and episodes like Marianne's case, those sort of things.
Yep. So what specific decision are you thinking of there, Paul?
Look, Marianne's case is I just don't have the citation of it in front of me at the moment. But situations where the child is not in a position to provide any consent, and it's effectively the parent who's making the decision. And this does come up from time to time with, in particular, Jehovah's Witness cases where child may require a blood transfusion and parents won't provide consent for the child to undergo that procedure. And it's then the Area Health Service having to trot off to the Supreme Court to make an application to get an order that this is a life-saving treatment that the child has to undergo, and then it becomes a court matter.
Yeah. So in terms of Tahir, though, there's two decisions here. There's one about continuing aggressive treatment, and there's one about providing pain relief. Are you talking about both those decisions being suboptimal?
I think the pain relief, if the mother's denying the pain relief and the pain relief is clearly put in place for the benefit of the child to alleviate their pain and the distress that they're undergoing, would it be a difficult task to have a consultant, a clinician, intensivist or someone of that caliber to provide expert evidence for an order to be obtained from the court under its parents patria jurisdiction.
Yeah, and you're right. That would be actually far more straightforward than the other decision, because the other decision isn't intervening, it's not intervening.
Yes.
Which is always more difficult. Peter?
Yes, I agree with Paul. I'd certainly be, and that was the experience on the similar matter that we had. We had the parents patria application ready to go. But as you say, it's complex because you need to address whether you're looking at continuing care at the same level, or whether you're looking at a substitute medical treatment decision in relation to significant treatment. But either way, the court has jurisdiction in any event. In relation to the pain medications, I'd be concerned about Tahir's human rights and the potential to breach those under the Human Rights Charter, in the sense of exposing him to treatment in a cruel, inhuman or degrading way. So I think that would be a consideration as well. Of course, there's also the route of going to VCAT and seeking an advisory opinion under Section 70 of the guardianship legislation, which is a very interesting pathway that I explored recently, and very rarely beaten path as well, or appointing a substitute decision maker through OPA. But generally with children, I think the Supreme Court is the inherent jurisdiction is the preferred pathway, and certainly very quick.
Yeah, so I'm just aware of the time, so we might keep going, because I want to get on to that idea of ruling parents or overriding parents, because yes, we can do it, but I want to talk a little bit about what that's like in practice for us here. And we might flick through these slides really quickly. We've talked about personal autonomy. If Tahir was 20 years old and typically developing and considered competent, and he wanted and refused, say, a blood transfusion, we couldn't override it. But if a parent refuses a blood transfusion for their 4-year-old child, yes, we can override them. So personal autonomy is not the same as parental autonomy. For that reason, I personally, in my practice, clinicians talk about it as parental authority, because it's not full autonomy.
Yes, so the way we would standardly consider respecting parental authority, or them exercising their autonomy as a parent, which is, of course, constrained by, I guess, the demand or the obligation to be acting in the child's best interest. That forms part of the I guess, the responsibility and the duty and the right to exercise parental autonomy is that you're acting in your child's best interests, and you're the one best placed to do so. So if we accept that, and what is standard practice and what happens mostly in this hospital is that clinicians are able to engage parents in shared decision making that's sort of family focused. They need to provide the information to parents in an understandable form to them, and give them a chance to think through their values, maybe help them do that, to work out what matters most for them as a family and that child within that family unit, and then provide their informed consent. The tricky thing that we're sort of working our way through today is, what do we do when parents as decision makers seems to push up against or be in tension with conceptions of benefit and harm to the child as seen by the treating team? That's when we've got competing principles. So some other types of ways that this can happen is when parents are deciding against treatment, not allowing their child to take part in activities maybe in the hospital or outside, taking them home earlier than is recommended, not bringing them in for appointments, or not following advice on medications, rehab, and perhaps shopping in alternative therapies. So that's when, so Lynn Gillam, the academic director here at our centre, has developed a model called the Zone of Parental Discretion, which is an ethically and a legally protected space, as mentioned by Peter earlier, where parents can make decisions for their children. They might be considered suboptimal It might be that you're putting orange juice in your toddler's bottle rather than water or milk, but we wouldn't remove children from the care of their parents for things like that. We provide broad scope and we allow parents to make suboptimal decisions in parenting all the time, and that does cut across into healthcare. And that is, though, constrained by the idea of the harm principle, or where the actions or the inaction are going to cause significant harm to the child or restrict or reduce their right to an open future. So there's a broad and big zone, of a green zone, of where parents can make decisions, even if we think they're not the best decision from our point of view, we permit them to do so. Then there's a grey zone, which is like to hear, where we think, well, maybe mum can decide, yes, we need to intubate, but can she decide that we can't provide pain relief to Tahir? So it's like, what's in the grey? And then there is the, I guess, the other side, which is the harm, at which point clinicians can override parental decision-making.
So, these are some initial questions that we ask that bring us to that end point. So, for instance, if we take the refusal of pain relief, we think about what will be the effect of the child of doing what the parents want, or in this case, the mum. So not giving the pain relief, well, Tahir's going to be in pain, and we're not expecting that pain to go away. We're not expecting it to be resolved by any lesser methods. So how bad it is, in fact, in comparison to what would otherwise happen. And as Paul suggested, it's seen as a human right not to be in pain, or to do something about pain and suffering if we can do it. And we can treat this quite effectively with strong pain relief. We know that he will be more comfortable. How likely is a bad effect? It's pretty... You don't need to be a clinician to know that there's going to be a bad effect. Pain is bad. Pain doesn't feel bad. So we have to determine whether that consists of significant harm to the child. Maybe just raise your hands if you think leaving Tahir in pain would consist of significant harm to the child, so much so that we would override mum's wishes. A couple of hands. A couple of thumbs up, yes. So there's a strong ethical reason to give Tahir pain relief, even though mum does not want it. The tricky thing we find in practice is thinking through how that looks. So how does that look in practice? What harms would that, what would ensue by going against the parents' wishes? So in this case, mum is the primary support for Tahir. She's a primary communicator for Tahir, and she's integral to his well-being. So if we have to think about what we do by going against her wishes in terms of trust, in terms of rapport, in terms of the relationship. And I'm not saying this outweighs Tahir's right to pain relief, but in reality, we really do have to consider how that is going to be managed, because that goes to the harm-benefit balance as well. And in practice, what does that mean? And some parents, we have to think about, are they going to physically stop someone from doing something that they don't want to do? And does that mean they need to be removed from the room? And what effect does that have on the child? And what effect does that have on the atmosphere in the room? So not only harms the relationship with clinicians, but actually might directly harm the child, or indirectly harm the child.
And maybe we have a better understanding if we have a chat to mum to try and unpack what it is that's her concern about the medications that we're going to be given for pain relief. And maybe she's grounding it in a religious belief, but maybe she's terrified because she's had family members on opioids before and has seen the addictive nature of some of these medications, and maybe with some education or a bit of a chat, she can be talked around to be more comfortable, or there can be some discussions about alternative pain relief methods if she does have certain concerns about a particular one.
Yeah, so where that leaves us is that we have an ethical imperative to try in every way we can to bring the parents along the journey with us to work with parents. And that depends a little bit on thinking about the time that we've got. So if Taki is there in front of us in acute pain, we don't have a lot of time to make that decision. So we might not be able to have the time to have multiple discussions with mum, to maybe get someone from her community in to speak with her about pain relief, to provide her some education if she's worried about the side effects of opioids, all of that. We might not have that time. But for instance, if we have a child that's with a severe brain injury that's ventilated and that the decision has been made that it would be in the child's best interest to extubate and allow him or her to die, and the parents don't want that to happen, we do have time if that child is well sedated and comfortable. It's not they don't have a good quality of life or maybe any quality of life, but if they're not suffering, or if we believe to the best of our abilities that we can when someone is heavily sedated that they're not suffering, we maybe have a bit more time to work with the parents. And so that's a lot of work here goes into working with parents so as not to override them, even when it's legally and ethically permissible.
So I'm just conscious of the time. We might advance to the final slide that closes off to here to find out what happened.
So yes, so he, and this is what happened in this case, he slowly improves over the next week. So he didn't deteriorate, he didn't need intubation and ventilation this admission. And there were multiple discussions with Summer, and she agreed to some palliative care input to manage his pain and distress. So our palliative care team is very good at managing pain and distress. And there were certain medications that she disagreed with, but she accepted others. So he was able to be kept comfortable, and he was eventually discharged to the ward. And he's expected to bounce back pretty quickly, because that's the nature of where he's at in his trajectory. And there's no clear plan about limiting further invasive interventions. So that's where we're sitting now. Just like to hear if anyone's got any thoughts on that outcome. Is that good or bad, or a few thumbs up? That's a good outcome. Does anyone want to comment on why they think that's a good outcome? No? Chris,
well, I think, yeah, well, look, it seems like there's been good communication between the ward and the mother, and I think the fact that the mother has agreed to palliative care. But yeah, it certainly seems the fact that the mother is agreeing to pain relief, whereas that was a sticking point before, really looks like progress to me, and that's why I think it seems like a really good outcome.
Yeah. And we saw it as a good outcome too, because for the first time she'd agreed to have palliative care input, not to discuss palliation, but for pain and distress. But it's an in to have those expert discussions with the palliative care team.
So I think it's a credit to all the clinicians here at the hospital that more applications are not made to the court, because I think, as you can see, there's so much fertile ground for that happening. But I think if we keep returning to the principles and respecting parents as the decision makers, even in cases where we consider that to be overriding reasons to override it, it's about preserving the therapeutic relationship and remembering what that relationship is for you with the decision maker, but also for the child there. So even though Tahir can't speak and can't let us know what he thinks, trying to honour and respect his family unit and his mum's wishes for him is really at the core or the forefront of what we do, and then trying to balance their wishes with what we would like to do to provide optimal care is I guess the key challenge.
And as we suspected, we had a second case for you, but we thought we might not get onto it. But we'll forward the slides to Chris, and you're welcome to distribute them to look at the second case, which was more about an adolescent refusing treatment.
Yeah, thanks, Jenny. So we will pop those slides up on the website with the recording of this lecture for people to see. So look, I just want to say thank you so much for a really, really interesting, stimulating talk. I've really enjoyed it, and yeah, like that, we'll wrap up there. So thank you, everyone, and we hope to see you at the October Helen seminar. So have a good afternoon, everyone.
Thanks,
Thank
Chris.
you.
Thanks, everyone. Bye.